Hi, this is Elliot Fishman, and welcome to the latest version of You Make the Call. You remember now how this goes. You have one slide, two images, and we need to come up with the best diagnosis. There's a little bit of clinical history, but the rest is you and me trying to think about it. So let's get going. This patient had abdominal pain and atrial fib for 2 days. What's the finding? At first glance, you don't see a whole lot going on, but if you look really carefully and you look at the SMA, there's a clot in the SMA. More distally, the SMA is small, but it's visualized, okay? This is a clot. With atrial fib, you can get emboli. SMA is a common location and is easy to miss. If you miss the SMA embolism, you may get an infarcted bowel and the patient could die. Just to show you I'm breaking the rule, but I didn't quiz you on it, look at the sagittal view showing you the clot in the SMA. My rule here, as I've always said, you always got to look at the sagittals for many reasons. But if you don't look at the sagittal, things that involve proximally or more distally, the celiac or SMA you're going to miss. This is a classic example of a case that was missed because it looked good proximally. There's no plaque. But in the middle of the vessel, you lost everything. Sagittal view makes it easy. What about this case? Flank pain and atrial fib. Remember we spoke about embolic phenomena, and we spoke about SMA clot and occlusion and ischemic bowel. Here what you see, mainly in the left kidney, but also in the right, is decreased attenuation. Yes, in the right circumstance, you could at least consider pyelonephritis, but this is not the right circumstance. This is a classic example of a large infarct in the left kidney and a smaller infarct in the right kidney in a patient with atrial fib. Back pain and weight loss. Nothing very tricky here. I just thought I liked this infiltrating case in the tail of the pancreas. Yes, I could consider lymphoma, small chance. With the right history, or even at least to consider it, autoimmune pancreatitis, which can give a sausage-shaped appearance, but I would like to see haziness around the gland, which I don't see. And what this was an infiltrating adenocarcinoma of the patient's pancreas. Nothing very tricky, but something you need to get right. Patient with weight loss, what do I see? I see markedly thickened gastric folds, Menetrier's disease, lymphoma, bulky adenocarcinoma, but then I see a mass in the body of the pancreas, which is vascular, which means I'm dealing with a neuroendocrine tumor. So now you say to me, neuroendocrine tumor and big gastric folds, then I'm saying functioning neuroendocrine tumor and a gastrinoma, which gives very large folds. Remember, patients with MEN1 commonly get neuroendocrine tumors, which end up being gastrinomas. A beautiful example of really dilated gastric folds and a gastrinoma. Great case. Pancreatic mass. Well, this is a good case. There's a mass in the uncinate process that's solid density with 2 punctate calcifications. Could this be adenocarcinoma? I guess so, but it's more solid than the rest of the tissue. It's not very vascular, but it's brighter, denser than the rest of the tissue, and it has calcification. My rule is, if you see dense pancreas, even if it's not hypervascular, and usually it is hypervascular, but if it's just like this is a neuroendocrine tumor. It's atypical. You got to think about adenocarcinoma, but how often do you see adeno with calcifications, unless maybe it arose in a patient with chronic pancreatitis, which does happen, but this is only 2 dots. So this was a neuroendocrine tumor in the head of the pancreas. What a great case. What about this case? Incidental pancreatic mass. Mass in body of pancreas that's cystic with septations. Yes, you can consider serous cystadenoma, possibly. It's not an IPMN with that septation, but hopefully you would know this patient was 45 female. That's the age range, and that's the location you typically see a mucinous cystic neoplasm, MCN, of the pancreas. A really nice example. The thicker the septations, and over 4 cm is typically going to be associated with these are malignant MCNs. Typically, however, we think about all MCNs as potentially malignant, and they're all going to be resected. A lot of work going on to maybe rethink that process. Patient with back pain, large pancreatic mass, kind of funny looking. There's no dilated pancreatic duct. Could it be lymphoma? Yes. Could it be adenocarcinoma? Very bulky. Usually I like to see something else, but it could be. But what this ended up being, large mass, not very vascular or hypovascular, no dilated pancreatic duct, which is typical, a hallmark of adenocarcinoma. Lymphoma is a thought, but you better be thinking neuroendocrine tumor. And yes, I know neuroendocrine should be vascular, should often have calcification. Here it's soft tissue, there's no calcification, and there's no increased vascularity. An excellent example of a large neuroendocrine tumor. Incidental pancreatic mass, it's well-defined, low density, lobulated against the gland. It's hard to tell if it's arising from or abutting the gland. That's the typical appearance, that scalloping, the low density, the homogeneity. That's a lymphoepithelial cyst of the pancreas. Okay, just a wonderful, wonderful example. Okay, we're nearing the end. Curtains away. Cystic mass body of pancreas, septations, atrophic distal gland, no common duct dilatation. This is the appearance. It doesn't look like an MCN. MCNs are more cystic with larger cysts and septations. Doesn't look like an IPMN. It's not a lymphoepithelial cyst. This is a classic appearance of a serous cystadenoma. So with that, hopefully we shared some time together. We discussed some cases together. And I'll see you soon. Bye, guys. If you like this video, make sure to subscribe to the CTisus YouTube channel. You can also visit us at ctisus.com for even more videos, plus quizzes, pearls, protocols, and oh so much more. We're also in the App Store and have well over a dozen apps for iPhone and iPad, all completely free. Thanks for watching.